Hi, this is Jon Roffman. I'm a managing principal of ZS Associates Oncology Vertical. I'm joined here at ASCO 2018 by Dr. Debra Patt. Dr. Patt is the Executive Vice President of Texas Oncology and the Director of Analytics for US Oncology. How do we set standards for what is error-free or usable information from these tests? You know, we see 23andMe just came out with this test you can do at home, and it detects just a very, very small subset. I think it was like 1.5% of BRCA mutations in women. But now we're going to have patients coming and thinking, maybe because I took this test, that gives me some certainty, when in fact there's a lot of caveats to what specifically it's telling us, right? And even in the space in practice with Foundation One and with Oncomine and with Garden 360, the concordance rates of these tests are not perfect. So how do we figure out when we have the right information and when we have usable information and when we have to be very skeptical of the information that we have?
So I think that we need a lot of education in this space, and I think we need a lot of trials in this space, because there's hazard in having action that may not be nested in evidence based on what may be erroneous information. So for example, I saw a patient recently in clinic that had a variant of unknown significance, BRCA mutation variant of unknown significance, and they came for consultation around risk reduction when they really didn't have a strong family history of cancer. There was nothing that was inherently problematic about their risk that would have led to them testing, other than they just wanted to be tested. And they have a variant of unknown significance, and they think that they need to have risk-reducing surgery and heightened screening and all of these other potential secondary consequences of a test that we would say today we interpret as normal, right, with the caveat that we need to continue to follow it. And so that's just one example of the many, many examples we see of some of the downstream consequences of uncertain or erroneous information that can guide decisions. And the best cure for that is shine a light on it. Give education to clinicians, give education to patients. You can't not give it to patients, right? Because it's patients' information. If they want to have genetic testing and it's $50 or $100 for them to do it, they're going to get genetic testing, and it's their right to do that. But there's a lot of hazard and misinterpretation of results. And we, as clinicians, as physicians, need to help guide and direct that better.
As we're here at ASCO 2018, and the topic is precision medicine, what are you most excited about when we think about next generation sequencing and targeted therapy? What most excites you about what you're seeing and hearing, either here at ASCO or just in the oncology marketplace?
So I'm very excited about some of these small prevalence, low prevalence mutations that have highly selective targets. So I think, you've seen stories develop out of Luxo Oncology last year with the NTRK fusion protein mutations and lacratinib, and this year with the RET story being something that has low prevalence. These are 1% to 2%. Clearly dependent upon next generation sequencing to identify these patients, but highly selective targets. And what that means is that these drugs have been highly effective with low toxicity. So I'm excited to see those kinds of drugs get developed. It is tremendously meaningful for patients, because as you add the 1% to 2% to 1% to 2% to 1% to 2%, eventually you're getting a big chunk of cancer care, and it matters.
Well, thank you so much for your time, Dr. Patt.
Thank you.
It's been a pleasure talking to you, and hope you enjoy the rest of your ASCO.
Thank you.